Hi, everybody. We're going to talk about diabetes mellitus, and we're going to start with type 1 diabetes. So, if we just talk about diabetes in general, you guys have already learned a lot about it this semester, but it's the leading cause of death in the US. Some say that it's actually at epidemic levels in the United States, probably due to our food culture, our culture of, indulgence when it comes to foods and not wanting to limit ourselves, despite the fact that we have, good knowledge about what we should be eating and drinking for our health. Diabetes can lead to heart disease, stroke, blindness, chronic kidney disease, acute kidney injury, and amputations. And since diabetes is so pervasive in the United States, nurses really must know what this is and how it's treated, because even if you choose to work, let's say, in the operating room, or you're going to work on an oncology unit, inevitably you're going to have patients that, in addition to whatever their primary issue is, they're also going to have diabetes, and that has to be managed. So it's something that we as nurses, whether you're going to do peds or you're going to do adults, I would say probably the only group that may not have to know much about diabetes is people who work in the NICU, work with infants. But even then, infants have their own blood sugar issues. So learning this is critically important. Okay, so let's talk about the pathophysiology of glucose control, and then we could talk about glucose regulation and talk about diabetes in general. So glucose control occurs primarily by the excretion of insulin, and insulin is excreted by the pancreas. This is the pancreas, this kind of funky looking little piece of tissue right here. It doesn't look all that exciting, but essentially you cannot live without it. So pancreas is behind the stomach and between the duodenum, which is this right here, and the spleen. You can live without your spleen, actually. Inside of the pancreas, there are these little clusters of cells called the islets of Langerhans, and they're responsible for the endocrine function of the pancreas. They are the cells that excrete the hormones that the pancreas puts out. And we'll go next. There is a great photo or a great depiction in your book illustration of the islet of Langerhans and the cells that make both insulin and glucagon. Okay, so glucose regulation. Glucose regulation is critical for life. You cannot live without glucose. Our cells need glucose as an energy source in order to do their normal work. So that can come in a lot of different forms, but essentially we need glucose. Our brain relies almost exclusively on glucose. And if you think about it, some of the symptoms of having low glucose or hypoglycemia are frequently related to the brain, right? Somebody becomes grouchy. Sometimes we call it hangry, where they're hungry and angry. Maybe they're a little confused. Maybe they're just not thinking clearly. They kind of have a brain fog. So these are common things that you'll see. So just proof that our brain really needs almost a constant source of glucose in order to function well. There's two hormones that regulate glucose. And I know that you've heard about and know about insulin, and that insulin acts to decrease glucose in the blood. but there's also glucagon, and we're going to talk about it because glucagon is used by nurses. There is an analog to glucagon that can be used to increase blood glucose for people who maybe have life-threatening hypoglycemia. So the way this works is that following a meal, the pancreas recognizes that there's increasing serum glucose levels and releases insulin so that that glucose can get into the cell. So if you don't have insulin, you have glucose, you've eaten a lovely meal, and you have plenty of glucose in your bloodstream. But if you don't have insulin, it's like standing outside of a locked door. You're there, you want to go in, but you can't get in. And so I think one of the best analogies for insulin is to think about a lock and key analogy. Another one that gets used sometimes is a gate analogy, and I think they're both actually really excellent. So if you think of insulin as a lock and key for glucose, again, you have a lock and a key, so you can think about that. And without the key, you can't get in the door, right? So you can't get into the building. You can't move yourself from outside to inside, or vice versa if you're locked in. So, but in terms of glucose and cells, if you look over here, we have our cells, right? And the way that it works here is you have insulin, which comes in, think of this as a key, and it slips into its insulin receptor here, which is the lock. Okay, so insulin unlocks this glucose channel over here. You can see it here, it's closed. The glucose channel is closed. But as soon as the key, insulin, goes into the lock, the insulin receptor on the cell, then boom, the glucose channel opens, glucose can go in, and now the cell is happy. So you can see what a critical role insulin plays in glucose regulation. So insulin. This insulin is considered to have a hypoglycemic effect. Now stick with me here. You're like, wait a minute, but you just talked about insulin letting sugar into the cells. That's right. But when we talk about hypoglycemic, we're talking about low glucose in the blood, okay? So insulin causes glucose to leave the bloodstream, which is not a bad thing, and to go into the cells. That's okay. Now, we still need a base amount of glucose out in our bloodstream because remember, we're a system. We're on 24/7. So as soon as glucose goes into the cells, somewhere, more glucose is needed somewhere else. So we always need to have this supply of glucose, okay? So insulin promotes entry of glucose into the cells. We just talked about that. That is the lock and key mechanism. Insulin being the key that goes into the insulin receptor and then opens the glucose channel so that glucose can go into the cell. Insulin also provides for the storage of glucose in the form of glycogen in skeletal muscles and liver, right? Think about people who do like exercise or running. A lot of times they'll have like a glucose a high carb meal, which gets turned into glucose, before they go out and run. Or even during a run, they might actually have some energy tablets or bars or things they eat, which helps go ahead and replenish that glycogen in skeletal muscles and the liver. And it's stored there for when it's needed. It's stored there for when the body needs more glucose because glycogen can be broken down into glucose quite quickly. So insulin inhibits the breakdown of fat and glycogen. And that makes sense because we don't have to use fat or glycogen for an energy source if we have enough carbohydrates and glucose and insulin. But insulin does increase protein synthesis. Okay, so it helps us with breaking down, everything in our food. It inhibits gluconeogenesis, which is the production of new glucose from non-carbohydrate molecules. And I know this sounds confusing, but I think if you read over it a few times and look at it in the context of the rest of this lecture, it will make sense. Gluconeogenesis is the, making of glucose from our fat or from our muscle. So anybody ever go on a crash diet for a couple days and you're like, wow, I lost 5 pounds. That's amazing. Yeah, you probably lost some muscle. And the reason you lost muscle is that your body, and not having enough glucose, said, what energy sources are there? I'm going to go over and try to tap those. And muscle is much easier to turn into glucose than fat. So muscle happens first. Okay, let's go on. So that's insulin. Now we're going to also talk about glucagon. Glucagon is also secreted by the pancreas, okay? And glucagon is secreted when blood glucose levels are low. So let's say now it's, 11 o'clock. You're sitting in nursing 316 and you're just starving because you ate breakfast several hours ago. Your pancreas is secreting glucagon to try to hold you through until your next meal. Okay, so its primary role is to maintain blood glucose levels between meals. Glucagon has a hyperglycemic effect because its presence causes blood glucose to rise. That's a good thing. So again, if you break down the Latin, you have hyper, which is high, glyc, which stands for glucose, and emic, which is blood. So hyperglycemic means that there's high sugar in the blood. And again, remember, where the sugar is very important because if sugar's high in the blood, that means it's low in the tissues, which means that the individual, the body is not getting the sugar it needs for those cells to function. Conversely, hypoglycemia is when there's not enough glucose in the blood to feed, to go out into the tissues and feed those cells. And this is, again, that pre-lunch kind of got the jitters. Like, this is when you say things like, I'm starving, I'm so hungry, I really need to eat. So our bodies are pretty amazing that way. Okay, so this is very good for you to know, and it's something that you need to go back and review because we've talked about it as we've talked about many of these drugs. One of them we've not talked about. But you need to know some of the drugs that we use for other things that cause hypo or hyperglycemia. Hypoglycemia, alcohol can definitely cause hypoglycemia. Although the other thing that alcohol often does is it lowers our inhibitions. And so I don't know about anybody else, but when I used to drink alcohol, I also like to eat. So I think we have a kind of a natural way of counterbalancing that. Lithium is a drug that's used for psychological diseases, mental health diseases, and so just so you know. ACE inhibitors we've talked about. So ACE inhibitors cause hypoglycemia, and beta blockers can also cause hypoglycemia, right? So these are important to know, especially if your patient with diabetes might be taking these medications as well. And then hyperglycemia. What drugs cause hyperglycemia? So corticosteroids, we have already learned this. Remember, corticosteroids, it's like getting a little dose of stress, which sounds bad, but in essence gets us ready for fight or flight, and we need sugar for fight or flight. So then NSAIDs can also cause a little hyperglycemia, which is interesting. So perhaps someone who is pre-diabetic, but also takes NSAIDs every day for maybe an unrelated ache or pain, the two of those could definitely lead to hyperglycemia. And then diuretics can also lead to hyperglycemia. Okay, onward. So diabetes mellitus, you don't often hear the second word. These days we tend to just say diabetes, right? But the true diagnosis is diabetes mellitus. And the Latin origin for this is diabetes, which means passing through. And it refers to the high urine output of diabetes, the polyuria that we see. And then mellitus means honeyed or sweet, refers to the sweet nature of urine in this condition, which is glycosuria or glycouria, which is having high sugar in the urine. If you, as a person who does not have diabetes, checks your urine and does a dipstick, there should be no glucose in there. Our bodies should be hanging on to glucose, unfortunately, but hang on to glucose and store it so that we have it for our stores down the road. Remember, if you think about us sort of in caveman times, we were people who may not have a meal for 3 or 4 days. So we had to eat when we had food, and then we would store fat, store glycogen, so that when we weren't eating, we could make it. So, and if you think about these terms were first used around 250 to 300 BC. Just a long time ago, people, 2,500, 2,300 years ago. And so, they were aware of diabetes back then. And my guess is that people weren't aware of it because if they really truly had type 1, they wouldn't survive. Okay, so type 1, that's what this whole lecture is focusing on. And there's going to be a separate lecture on type 2. So I don't want to confuse you by talking about anything type 2 right now. So we're going to stick with type 1, but you're going to see that there's some parallels and crossovers. Type 1 is actually the least common type of diabetes. Most of the people in the United States that you see in the hospital, they have type 2. And that comes as a result of lifestyle, eating, environmental factors. But there is a group of people for whom they have type 1 diabetes, better known as insulin dependent. Sometimes you'll see it written as insulin dependent diabetes mellitus, IDDM. But again, only 5 to 10% of all cases of diabetes are type 1. But it is by far the more deadly form of diabetes. It is one of the most common diseases of childhood. As a pediatric nurse working on med-surg floor, I saw many children diagnosed with type 1 diabetes, just fine, not, doing okay, and then maybe, a few weeks or a few days of symptoms, and then they come in and boom, they're told that their child has type 1 diabetes. There are 25% of cases, though, that are diagnosed in adulthood. I had a former student who was diagnosed at 25 with type 1 diabetes. So it is possible, it's just less likely. So what is it? Why do some people get it and some people don't? It's caused by an autoimmune destruction of pancreatic beta cells. So your beta cells make insulin, And if they are destroyed by an autoimmune process, now you have a lack of insulin secretion. And remember, if you don't have insulin, you don't have the key that opens the lock so that sugar can go into the cell. It's thought to be, the development of type 1 diabetes is thought to be not just one thing, but sort of an interaction of genetic and immunologic and environmental factors. There is a strong genetic component. We do know that type 1 diabetes can run in families. So that tells us it's a genetic trait that can be passed down. But you have this whole field of epigenetics, which is, yes, you might have the genetic kind of underlying propensity to develop type 1 diabetes, but it might be that what really sort of flips the switch and makes it so that you actually turn into full-blown type 1 diabetes is maybe an environmental thing or an immunologic thing. Maybe the patient had a virus. We often see this in pediatrics where children will have a virus of some sort, and then a few weeks later, boom, diabetes. So it's not unusual for parents or children to give a history of having a viral illness some weeks prior to being diagnosed with type 1 diabetes. So again, your body is not making insulin at all. And so the signs and symptoms are primarily hyperglycemia. Okay. That hyperglycemia, if it's very, very high, I mean, sometimes blood sugars, normal blood sugar is like 70 to 110. Sometimes these kids would come in with blood sugars of like 600, 800. And so that can also cause, again, remember your brain needs sugar. So if you have a sugar level that high in your blood, that means it's all staying in your blood and none of it's going to your cells. So your brain is really suffering without that. I remember a mom that came in and said, she brought her daughter into the emergency department. One of our students was there for the day, and she said to the nurse, I don't know what's wrong with her. She's just not herself. And the nurse said, well, tell me more. Like, what's going on? And she said, she's not herself. I don't know what else to tell you. And the nurse said, okay, tell me what she's like normally and tell me what she's like now. And the mom described that her daughter is normally very competitive, very articulate, very measured out, like very much had a plan for everything. She said the last week she had been kind of flighty and unfocused and was sort of having a hard time talking, not talking normally, but talking at her normal level of speech. And sure enough, when they did a blood sugar in the ED without any other symptoms, this child had a blood sugar of over 700. Okay, so that's hyperglycemia. That's number one. Then you might see the 3 Ps. And I think that's what the little asterisk is for there. We call these the 3 Ps. Polyuria, which means lots of urine. Polyphagia, lots of hunger, wanting to eat. And polydipsia, which is thirst. So lots of urine, lots of eating, lots of drinking. Well, think through this. So the lots of hunger comes from cells that feel starved, right? The cells are telling the body and your brain, hey, I need to eat, I need to eat. There's no sugar here, I need sugar, I need sugar. So the patient feels hungry, but also the patient has such high blood glucose levels that the body's also saying, oh, I need water. I need to dilute this. I need to get this, I need water in here. I need to get this out of my system. And then polyuria happens because sugar is going out with the urine, and sugar is a big molecule and it tends to hang on to water. And so water is going to follow that sugar right on out the door. Um, so glycosuria, we've just talked about that. That's sugar in the urine. So in addition to high volume of urine, it will also dip or test positive for glucose. It'll be high, high, high. When you dip that dipstick in, it'll be as the highest percentage, like 3+ glucose. They'll also have weight loss. Well, again, think about it. If the cells don't have any glucose, they're going to try to make, the body's going to try to make its own, right? So there's a lot of fat and protein breakdown as the body is trying to get enough nutrients to keep itself going. And then fatigue. Again, lack of sugar, lack of energy. So what kind of tests do we use? We use hemoglobin A1C. That is a blood test, and it measures glucose control over 3 months. It's not a good test to do just to see what your sugar is right in the moment. It won't tell you that. But it's a good test to see what your control is over time. And so this is typically the test that gets done when we're looking at people and worrying about type 2 diabetes, right? But it still is a test that's used for type 1s because it tells us how well they're able to control their blood sugar with insulin. Normal hemoglobin A1C is less than 5.7. Pre-diabetes is 5.7 to 6.4. Again, this would these last two tend to be more things that we look at for type 2 diabetics. But again, and diabetes is, you have type 2 diabetes if you're 6.5 or higher on your hemoglobin A1C. So that's how people are diagnosed with type 2. Whereas type 1s, this is used more for looking at what their control's been over the last few months. You can also look at a fasting blood glucose, and you need to be fasting for 8 or more hours, so like overnight for sure. And if it's greater than 126 grams per deciliter, that's also considered diabetes, usually type 2. And again, a random blood glucose that's greater than 200. And I try to remember to tell you guys, well, I can tell it quickly. When I was in a new grad, we got a giant box of See's candy, humongous box from a family. And I used to work evening shift, which was 3 to 11:30. And about 9:30, 10 o'clock, most of our patients were asleep. And of course, we were tired. And so we started eating chocolates from the See's candy box. And one of my coworkers said, oh, let's eat it and see if we can get our blood sugar to rise. Well, we ate and ate. We stuffed ourselves full of chocolate and kept checking our blood sugars using the glucometer. And guess what? Our blood sugars never got appreciably high. They were still in the normal range. And that's because none of us doing this were type 1 diabetics or type 2 diabetics. We have healthy pancreases, and as soon as we would eat sugar, our body would spit out insulin. And I'm sure what we were doing is we were just doing a fabulous job of A, delivering sugar to our cells, and B, delivering all the extra sugar to other places to be stored for later. So yeah, so you should not have a random blood glucose of greater than 200. Now DKA is very much a type 1 diabetes problem. Doesn't mean that type 2s can't have this, but this is primarily a problem of type 1s. And it occurs when blood glucose is too high. Because again, type 1s have no ability to deal with blood sugar without taking insulin. Their own body is not putting out insulin. And so if somebody's blood sugar gets really, really high, glucose is unable to enter the cells. Lipids, fats are used as an energy source. And when you break down lipids, you get ketones. Ketones are a byproduct, they're a waste product of lipid breakdown. So then those high levels of ketones, which are acidic, lower the pH. Remember, acids lower the pH. So they lower the pH of the blood, which causes diabetic ketoacidosis. Our bodies need to be in a very tight, controlled range of pH. Basically neutral, right? We need to be neutral. And so if all of a sudden we're acidic, we start having problems. This usually develops over several days. It doesn't come on like, 1 minute you're fine and the next minute you're in DKA. So there's usually symptoms that the patient's not feeling well. And this makes it difficult for patients who are type 1 diabetics. If they start vomiting out of the blue, it's hard to know, do I have a tummy bug or am I in DKA? So one way they know is by checking their blood sugar. But you'll have polyuria, polydipsia, nausea, vomiting, severe fatigue. You can have huge changes in your mental status. So level of consciousness. So you could go into like stupor or coma, which is where you're unresponsive. And then you can actually die from DKA. And this is what would happen before we had insulin. And patients who were diagnosed with type 1 diabetes died. And still today, in many developing countries where healthcare is not good or resources are poor, people die of type 1 diabetes because there is no treatment available in their part of the world or in their, wherever they live. So again, DKA, something that we often see at diagnosis. Sometimes this is how we diagnose type 1 diabetics, is they're in this state already. Or it happens when type 1 diabetics are unable to achieve good control. And maybe, usually it's like a layering effect, like there's an illness and then, something else and something else. And all these things kind of, maybe they couldn't get their insulin prescription refilled or whatever. And it ends up being sort of this layers of problems that end up in DKA. Okay, now we're going to talk about the prototypes. And we're going to start with insulin. So while you're essentially learning insulin as a single drug, it's not a single drug. There are many different kinds of insulin. I want you to learn about 4 different types. I'll talk about that in a minute. But it's sort of like learning the prototype, right? Once you know one insulin, you know them all. So I'll show you in a minute how they're different. But essentially, all types of insulin work to maintain healthy glucose level in the blood while ensuring that the body cells get the glucose needed to function. Okay, so all these insulins are keys that unlock the insulin receptor that opens the channel for sugar to go into the cell. Okay, most have a similar risk for hypoglycemia. That is probably the biggest side effect of insulin. And we'll talk a little bit more about that. There's one type that doesn't cause hypoglycemia. So before we go into the actual prototype itself, there's some terms that you need to know. So the differences between these 4 different kinds of insulin is what's on this slide: onset, peak, and duration, administration, and timing. That's what makes these 4 different, but otherwise, insulin is insulin. So I hope that helps a little bit. We'll talk about it more in class. but we use all these different types of insulin, and the reason we do that is for different kinds of glucose control based on what the patient's doing in their day. Are they getting ready to exercise? Are they sitting down for breakfast? Are they getting ready to go to bed at night? And so we have these different types of insulin that get used. So one of the things I'm going to want you to know about each of these 4 types of insulin is I'm going to want you to know their onset, their peak, and their duration. Onset is the length of time before insulin reaches the bloodstream and actually begins to lower glucose. So think about this. If I swallow an ibuprofen tablet, it's going to take probably at least 30 minutes for it to start working. This is the same kind of thing. Once we give insulin, how fast does it begin to lower blood glucose? So that's onset. Peak is when the insulin it's been administered, it's in there, and when is it just working at its maximum strength for lowering glucose? Okay. And then duration is how long does that insulin continue to lower blood glucose? So sometimes we've talked about drugs that have a long duration of action. And this is really the same thing. So how long do they work? I mean, if I give insulin and, it onset is 5 minutes, it peaks in an hour, and it's done in 2 hours, that's very different than if I give insulin, it takes an hour for it to start working. It peaks in 3 to 4 hours and it's still there 8 hours, its duration is 8 hours. So that's the difference. Also administration wise, the really easy thing about insulin is it's all given sub-Q except for one, which can be given IV or sub-Q. There is no oral insulin. Insulin's destroyed if taken orally. It's destroyed by the liver. So again, it's one of those drugs that first pass effect is devastating to the drug. So it has to be given sub-Q, or in the case of regular insulin, it can be given IV. And then timing is when is it given in relationship to eating. Okay, so this little table right here is going to become your little best friend, and you need to have this memorized for the exam. And really, this will serve you so well in clinical to know this and not have to look this up every single time. So first type of insulin is called insulin aspart. There's many different brands. Novolog is a common brand. And it is what we call rapid acting insulin. This is I'm getting ready to go to Jack and Dan's and I'm going to eat a giant hamburger or French dip with fries and I'm getting dessert. Okay. So the onset is 10 to 20 minutes. The peak is 1 to 3 hours and the duration is 3 to 5 hours. So think about it. This needs to be given just before a meal. And if you're a nurse on a unit in the hospital, you're not going to give this insulin until the patient's tray has actually come to the floor and you have talked to them and they are planning on eating. So you would not want to give this insulin 10 minutes before the trays are supposed to be delivered, because what if something happens? What if the cafeteria lady gets, bumped into by the supply cart and all the trays go on their sides and now it's another 40 minutes before trays come to the floor. Now you have a patient that is probably going to become hypoglycemic before you get them a tray. Insulin regular, you could put a star by this. This is the original insulin, the original first insulin we ever had. It works within, its onset is within 30 to 60 minutes. It peaks in 2 to 4 hours, and its duration is 5 to 8 hours. Sub-Q, you need to give this 30 to 60 minutes before a meal because remember, it's going to take 30 to 60 minutes for it to work. And then this is the only insulin that can be given IV, the only one. This is very important to know. If you have someone that comes in DKA and their insulin is 900, we are probably going to be starting an insulin drip, meaning we're going to be giving them IV insulin so that we can fairly rapidly get their levels down. We're going to be checking blood sugars on the regular to make sure that we know what's going on. Okay, so that's rapid, short, and now we're at intermediate. This is what you'll sometimes hear as NPH. NPH insulin is intermediate acting insulin. Its onset is 1 to 2 hours. So a little bit longer, right, than regular. Its peak is 4 to 12 hours, which is really out there a ways. So insulin I'm giving at 7 in the morning could be peaking still at 7 o'clock at night. And then its duration is 18 to 24 hours. So this is what we call intermediate. Somewhere between 3 to 5 and here at 24. This is 18 to 24. This is also given sub-Q, usually given with the first meal of the day, as you can imagine. And then sometimes it's also given at night to do nighttime control. So that's NPH. And then you have what's called insulin glargine. Oh, sorry, that should be a quotation mark, not a colon. And it's called Lantus. There's another type too. I can't remember the other brand name, but Lantus is pretty common. Many patients take this in addition to these other insulins because it gives really nice long-term control of your glucose, and there's something really awesome about this one. So the onset's 1.5 hours. So this is unrelated to meals, right? It's just something you're going to give for general overall control. It has no peak. So this goes in, it begins to work, and it stays at this very steady state, this very steady blood state all the way through until about 24 hours later. So you can imagine that insulin glargine, also known as Lantus, is given once a day. Now here's the kicker about this one. So this one is also sub-Q, but you cannot mix this with any other insulin. Whereas these insulins here, they can be mixed together. You can take a few units of this and a few units of this and give them together for both short-term and long-term control. But Lantus or insulin glargine cannot be mixed. And so it's a separate injection. Okay, very important slide. Must know, must know, must know. Okay, so I'm kind of going back to, our big picture insulin as a prototype and telling you about insulin in general. Its therapeutic class is that it's a replacement pancreatic hormone. Okay. It's a hypoglycemic drug, meaning that when you give it, it takes sugar from the bloodstream into the tissues, which is good. That's what we want it to do. It promotes cellular uptake of glucose, amino acids, and potassium. Okay, so think about this for a minute. This is kind of a, this is the key right here, uptake of glucose. That's what we're all about with diabetes. But let's just say you had somebody who, not diabetic, has a crazy high potassium, hyperkalemia, meaning it's high in their blood, right? Let's say their potassium's like 6.8, which means they are so at risk for a cardiac event. and you're like, oh my God, how do I can't just wait for it to go down. I need to do something. You can actually give someone a small dose of insulin and it will move the potassium from the blood into the tissues and decrease that risk of a cardiac event. So just a little FYI there, kind of a little fun fact. I have seen this done, maybe 3 or 4 times, often done in patients who are like end of life and their electrolytes are getting all whacked out. And this is a simple thing we can do to fix this problem, which just again adds time, usually in quality of life, quality to people's lives. We're not going to save them in the long run, but it can fix a short-term problem. Used as monotherapy to lower blood glucose in type 1 diabetes patients. Monotherapy means the only drug. It's one drug that's used to lower blood glucose in type 1s. Now, it's really interesting. It can be used in combination with oral anti-diabetic drugs in patients with type 2. And we'll talk about that when we get to type 2. This is also used for emergency treatment of DKA. And again, usually only insulin regular, right? Regular which can be given IV. Remember, emergency treatment, we would want IV insulin. And then it also gets used for gestational diabetes, which is diabetes that occurs during pregnancy. Some women get diabetes. They get it just during the course of their pregnancy, and as soon as they have that baby, their diabetes is gone. You'll learn more about that when you get to maternal newborn, but anyway, it's very interesting. And you cannot use oral anti-diabetic drugs in pregnant women. They're not safe for the baby. So that's why insulin is used for gestational diabetes. It's a real bummer for the mom, but it's temporary and it goes away. The administration of insulin, you want to ensure that the patients have sufficient food, that they are not hypoglycemic before administering. So you will always be checking blood sugar before administration. I think this is like, you work on a regular med-surg floor, you will become an absolute expert at this. Patients are good at checking their own sugars, but we also check them when they're in the hospital. And sometimes we check them on people who aren't diabetic, but we suspect might have a blood sugar issue, maybe after surgery or something like that. So very much the work of the nurse, and then taking that information and making decisions with it. You will also be rotating injection sites when you give this. So if you're giving it sub-Q, which most insulins are given that way, then it's given often in the back of the arm where you have a lot of nice, thick, heavy tissue back there, or in the abdomen. But you want to use sites that are different than the ones that the patient uses at home, because it can cause lipodystrophy, which is this sort of redistribution of fat, can make for like a bumpy area where injections are occurring on the regular. So you want to rotate sites. Okay, and then adverse effects. Numero uno is hypoglycemia. Biggest one, absolutely has to be thought about. And I said see you next slide, but I think it's a couple slides after this. And then I talked about lipohypertrophy, where injections occur. And so you have to be careful about that. But if you're going to remember anything about insulin, the biggest adverse effect is hypoglycemia. I've had the experience of giving a patient insulin at night, ordered insulin, and stayed within all the parameters of insulin. Sometimes if there's a sliding scale, like if blood sugar is between this and this, give this many units. If it's between this and this, give this many units. If it's between this and this, give this many units. So we'll look at that in class. We'll look at a sliding scale. But it's very interesting because even when you do that, I can remember going in one night, seeing a patient just covered in sweat. And sweating is definitely one of the symptoms of hypoglycemia. And I took her blood sugar and it was 30, which is very low. And oddly enough, I was able to turn on the light. She opened her eyes, was able to get her sip some orange juice, and she was okay. But I was shocked that at 30, she was able to still talk to me. It should not be given to patients with hypokalemia. So remember, I just told you that if you have potassium in your blood, it's going to make that potassium go out of the blood and into the cell. Well, if you don't have much in the blood to begin with, it's still going to do that. It's still going to take potassium and send it into the cell. So you could really exacerbate someone's hypokalemia by giving insulin. So you want to be careful, and it might be that you need to be correcting the potassium level with, a supplement of some sort in addition to giving them their insulin. Drug. I just want you to go back and look at that list, drugs that cause hypo and hyperglycemia, because those will compound problems, right? Especially hypoglycemia. So if you're taking something that causes hypoglycemia like beta blocker and you're taking insulin, the two of those together is going to exacerbate that risk of hypoglycemia. And then lab tests, we already talked about. You're doing usually a simple blood glucose, either a finger stick, or it can be done if you're drawing blood from a central line or you're doing a venipuncture. We can check blood glucose that way as well. That is the gold standard right there. And then to measure long-term control, hemoglobin A1C. It's very interesting to look at this in like teenagers, especially teenagers who may be having issues with compliance. Seems like it's pretty common for kids who've been diagnosed, let's say they were diagnosed at age 7 with type 1. By the time they get to be teenagers, they're like, I'm done with this. Like, I don't want to poke myself. I don't want to look different. I don't want to have a pump. And so they kind of rebel, and they can tell somebody, oh yeah, I've been doing a great job keeping my sugars in check. And then we check their hemoglobin A1C and find out, maybe not, maybe not, or maybe you have, and that's great. Treatment of overdose is glucose. You need to get glucose in, oral or IV. If you don't have IV, like they don't have IV access, let's say they're home and a spouse finds them at night in bed sweating and they check the patient's blood glucose and it's 30, and they can't wake them up, then they would give them parenteral glucagon. It's an IM shot that's given, and that will immediately stimulate the release of glycogen from the liver and help increase their blood sugar. So an overdose of insulin can cause death, which is why it is a 2-RN check, narrow therapeutic index drug, big time. If you want to watch something kind of creepy, there is a story about a nurse who was in Michigan, but I think he worked at a number of different hospitals, and he killed people by putting insulin into their IV bags, just regular IV bags. He went into the Pyxis and injected with a little tiny needle insulin into the bags. And then when people were hanging what they thought were just regular IV fluids, like normal saline or something else, they were really giving their patient an insulin drip, and patients died. I think he ended up killing as many as, I think they convicted him for 40 deaths, but he said there's as many as 600 that he killed, which is crazy and creepy and not the normal nurse thing. But don't get any wild ideas. Okay, glucagon. This is the only other drug I want you to know. So I want you to know insulin, and I want you to know the onset, peak, and duration of the 4 different types, and I want you to know glucagon. That's it. So 2 drugs, one's kind of big because there's some different formulations of it. And then glucagon. Glucagon's really easy. Glucagon is a glycogenolytic hormone, means that it breaks down glycogen. So remember, we have glycogen stored in our liver and in our skeletal muscles. So if you have someone who's very, very low blood sugar, you can give them this glucagon. I just talked about this, IM, and it will help release glycogen from the muscles and break it down into glucose so that it can be used. The liver will break it down into glucose so it can be used. It increases blood glucose, and it's an antidote really for hypoglycemia. It's used for severe hypoglycemic reactions, given IM, most likely to be used by a caregiver or nurse when patients unable to help themselves due to severe hypoglycemia. So the patient can, recognize it in themselves, and they can drink orange juice or take a sugar tablet or pop a hard candy or have some fruit snacks, those kinds of things. But if they can't, if they're so hypoglycemic that their level of consciousness does not allow them to either participate in eating or they cannot safely have anything given to them, then you could use glucagon. There's also a glucose gel that can be used too, that can be rubbed on the inside of a patient's cheek. But that's not one of your prototypes. And adverse effects of this is nausea, vomiting, and a low blood pressure. Okay, symptoms you must know. So you must know these: hypoglycemia. There's 6 for each. So again, some of these seem the same. For instance, I probably wouldn't use like a headache and say, is it hypo or hyper? Because that can be either one, right? So, but I do want you to know these because you're going to need to recognize them in patients. You probably know hypoglycemia more because most of us don't experience hyperglycemia. Our bodies are healthy. We have insulin that gets released in response to any kind of glucose load that we have. And so you won't feel this, but people with diabetes will. This dry mouth, increased thirst, blurred vision is a big one, frequent urination. So you need to know those. And these are symptoms that you're going to be teaching patients as well who are diabetic. Okay, in terms of administration of insulin, so some really just sort of like deep diving into this prototype. The right amount of insulin must be available to cells when glucose is present in the blood. Hence the timing between meals and when we give insulin. We're not going to go deep and dark into it now. You will do more so when you talk in your med-surg courses about diabetes. But I do want you to be aware of that. Hypoglycemia occurs when certain things happen. So I just want to talk about this a little bit. So if insulin's given incorrectly, okay, we don't follow the sliding scale, or we don't check the blood sugar, or we accidentally overdose and drop too much. It can happen when the patient doesn't have enough food, like they skip a snack or a meal. Maybe they're not feeling well, so they don't have an appetite. So something else that you have to consider with insulin, if they are engaging in sports without increasing their food intake or sports drinks, sugary drinks beforehand, we'll talk about this more, but exercise actually in many ways acts like insulin. It works almost like the key in the lock and allows glucose into the cell, which is one of the reasons why we have people exercise, part of lifestyle changes for type 2 diabetes, but we'll talk more about that later. You need to know its peak of action. You really need to know the onset, peak, and duration, but the peak is when hypoglycemia risk is greatest. That makes sense. That's when insulin's really working at its maximum level, And so you need to know that so that, if you gave somebody some insulin a few hours ago and they're now in their peak and they're telling you, gosh, I'm not feeling well. I am sort of, feel fuzzy headed and da 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 da. And they're giving you signs and symptoms of hypoglycemia, then you want to pay attention to that and think, oh my gosh, they're at the peak of when their insulin is working. I'm going to check a blood sugar because maybe they're hypoglycemic. And then also not increasing insulin during times of stress. Stress raises our fight or flight status, right? And when we're in fight or flight, we're always ready to, run from the scary monster. And so hyperglycemia is more likely during that time. The body's going to be making glucose available to us. So something to think about as well. And then hyperglycemia, which tends to probably also occur in the hospital, is not taking insulin when it's needed. And again, there's a lot of things in the hospital that can mess you up. Like maybe your patient's down for some long test and they're technically due for insulin while they're there. So they may come back and be hyperglycemic. But a lot of times, outside the hospital environment, it's due to inconvenience, cost, maybe insurance coverage, maybe illness that someone's trying to manage at home. It's making it challenging to manage their blood sugars, and also compliance. Okay, so what's your role in all this? Well, if you haven't figured that out by now, you will now. Patient teaching. So patients really need to learn how to manage their own care at home. And this is a huge part of why patients with type 1 diabetes are admitted for a few days. It's literally just to get intensive teaching and do demonstration, be able to learn how to draw up insulin, et cetera, et cetera. Blood glucose monitoring, teaching the patient about carrying snacks, having these things on hand in case patients need them. I was always a big fan of like graham crackers and a glass of milk or orange juice and maybe some fruit, whatever you have available on your unit. Exercise activity is excellent, but also can lead to increased hypoglycemia. So timing snacks and drinks around meals if you're going to exercise. Teaching injection techniques or management of the insulin pump. And caregivers should be taught as well to assist patient if unable to help themselves, hypo or hyper, right? So whoever's living with the patient needs to be also recognize the signs of hypoglycemia, hyperglycemia, and kind of understand the principles of treatment so that they can be a partner in helping the patient. And then this is a lifelong disease, and nurses must be compassionate about the difficulty of living with it and managing it. So, a lot of times we'll say things like, oh, well, they're just not compliant with their treatment, which is, a very judgmental thing to say. We don't know all the reasons for that compliance. And so, while it might be factual, we want to say it factually, and then our job as nurses is to get to the bottom of why that's happening and to begin to help our patient, advocate for our patient to get the care they need. Insulin pumps, just so you know, we're not going to really talk about this much, but we'll talk about it more in class, so I'll tell you more about that. There is a link here to a video that I would really love for you to look at. And then I have one more really exciting thing that I found. It was about a man who received a stem cell transplant. Remember stem cells? These are stem cells for pancreas cells. He received a stem cell transplant. He's a type 1 diabetic. So you might watch this for a few minutes. The other thing I wanted to say, and we'll talk about this in class too, is, nurses can become diabetes nurse educators. actually a certification, and it's something that hospitals often really want and are looking for. It's not something you can do without experience, so you won't be able to do it before you graduate or to try to get a leg up in the job um, hunting process. But you could think about it once you've been a nurse for a year or so to think about maybe I really want to go into diabetes education, and you would spend a lot of time educating families. I have just touched the tip of the iceberg. There's so much to know about it. So, all right, I apologize for the length of this, but very, very important stuff. Look forward to seeing you